So yeah, I am an LCSW. That is me in my provider days. I still am kind of shocked at the number of stock photos they've taken of us and use on all of our publication. But this is my team at West End, one of our satellite clinic locations, where I worked for about 4 years before becoming the manager here. Brief agenda. I will go through the basics of the current state of homelessness, common causes, the interaction of homelessness and cancer risk and screening, our basics of our services, how to access services with us, how to refer someone, some tips and guidance around working with a homeless population while they're in cancer treatment, because I've had several of my own clients go through it. Some of our recent advocacy attempts, legislature bills we're putting out there, and a little bit of COVID-19 info if we've got the time at the end of this, depending on how fast I talk and how many questions we get. So, current state of homelessness. I really like this. We use a lot of our clients in our work because they are the faces and the voices of what's going on in our world. And so this is a woman staying at one of our residential properties. We have 12 apartment buildings that are all supported housing, a mixture of low-income apartments and actual program, street homelessness program units. So she's staying in one of our apartment buildings. And she says, you never know when illness hits and all you want to do is go home. It's such a gut feeling when you're sick, and so you want to be home. So estimations right now, across the nation, we do this thing called the point in time count. It is a way of surveying and trying to count people experiencing homelessness. The estimate of 2019 was about 567,000, but this is restricted by the HUD definition. The reality of point in time is that the HUD definition doesn't include doubled up people staying on friends' couches, family members' couches. It doesn't include people staying in cars. It doesn't include people staying in shelters at certain kinds of shelters. It really is looking only at street homelessness, counting numbers of tents and then counting numbers of residents within a tent. It is, of course, voluntary and participation varies. We have a lot of folks that are not interested in speaking to us and are not interested in being counted among this, and we respect that, of course, especially around, the cold times. It's amazing how many people do find a couch or a friend or a family member that they can just stay with during the colder months. So it's a bit complicated measuring our homeless populations. Colorado by the numbers, very simply. Right now, this is last year's numbers for the Denver metro area. It is not insignificant, close to 10,000 folks in the Denver area, kind of broken out by completely unsheltered and a couple different demographics there. Denver metro attracts more folks because some of the outlying counties are a little bit less friendly, and there's a concentration of services downtown. So I always find that interesting that this number of 9,619 versus only 1,328. If we're just counting tents and that's how many people are homeless, we're missing all kinds of folks. Overrepresented populations, as folks who are already experienced in cancer research, I do not need to point out the connections between increased rates of disease burden amongst minority populations and the overlap here of overrepresentation for folks who are persons of color in the homelessness population. And I think we posted these slides, or we're going to post these slides, so any of the links in here you guys will have access to after. Causes, hopefully pretty common sense. I don't know about y'all's rent, but rent is high right now. I love these slide transitions in practice, and then when you do it, it's like it's so slow. I think the thing to know about broken systems and what goes on for our clients is how much of this interacts with each other, right? We know that families that are living in some of the low income apartments, some of the less well managed, I will not necessarily use the term slumlord, but poorly managed, poorly regulated apartment complexes that aren't managed by HUD or Section 8, aren't regulated. We know that a lot of them, the families in there experience increased rates of asthma, increased rates of allergies, breathing difficulties. We know that generational poverty affects rates of incarceration. We know that systemic institutionalized racism affects job opportunities. So really, when you look at these things, they're not siloed. They're all interacting with one another in terms of factors and why someone might become homeless. And of course, high cost of medical care. I'm a Florida transplant to Colorado, and this is the promised land to me, the land of expanded Medicaid for single adults. I had clients in Florida that were living in places that had dirt floors in the home. I mean, I'll call it a home, you know. So it is better than it could be, but we still got a long way to go in terms of caring for folks, especially within the donut hole, people that make too much to be over that 13,700-ish, I think this year, limit for Medicaid, but don't make enough to really be able to afford copays, really be able to afford transportation to get to treatment, to get to all of their appointments, who can't afford to take time off, who don't work in positions that give them ample amounts of time off that they can go for medical appointments that need to happen. Still a long way to go. I was kind of like looking at this, it's jarring to me how expensive it can be for a 2-bedroom apartment across the country. You know, Colorado, we're looking at $25.33 hourly wage. You know, minimum wage is still, I think, $7.25. So it's very easy to see when you kind of look at some of this data, why someone living on the edge gets tipped over into homelessness by something as simple as a change in a medical condition that in other countries and in other places in the world absolutely would not result in becoming homeless. Situational barriers. This is the common sense stuff, the things that I think are really obvious in terms of what's going on in this person's life. Sometimes the hard part is not that, it is what do I do with some of these things? Our role as supporting caregivers, our role in supporting clients while they're going through treatment. You know, how do you support someone while they're going through treatment and getting evicted, or having a new experience of physical disability, or having an exacerbation of an existing disability, depending on the form of cancer and what's going on for them. So you guys are working against a big mountain, I guess, in terms of life factors and helping someone manage oncology, manage cancer treatment while coping with all of this. I hope everyone may have heard of the ACEs study. Kaiser did a study around adverse childhood experiences. It's been talked about in quite a few social work trainings in my experience, but very simply, it is about 10 questions on experiences such as, have you ever had an adult in your home hit you? Have you ever had an adult in your home use substances to a place where they were impaired? And it correlated a significant amount of childhood trauma experiences, adverse experiences in early childhood, and later health risks, later increases in obesity, in hypertension, in cardiovascular problems, in cognitive issues, you know, pretty systemically across our bodies. You know, the experience of trauma and the experience of early abuse in life harms humans in a way that I think we needed to measure, although many of us kind of in our stomachs know this. So it's available online. You can take it yourself as well. It's pretty striking when you really kind of sit back and look at some of the data as to how life plays out in our health of our body. We always say trauma is often the cause, but is always the result of homelessness. Add in cancer treatment, add in, I know a significant number of cancer survivors actually experience some form of PTSD or acute stress due to that experience of possible terminal diagnosis, significant changes in their ability to work, what's going on in their life, just facing your own mortality in that way. And so the experience in and of itself of being diagnosed with cancer and having to go through that question of what's going to happen next to me, what's going to happen next to my loved ones around me, is traumatic, is heavy for folks to work around. And then add in homelessness. I don't know where I'm going to sleep tonight. I don't know where I'm going to eat tomorrow. I know I might have a plan. Let me get over to the Methodist church by 7, but I'm diabetic or I'm having stomach issues. And now I've had chemo the last couple of days and I'm feeling sick and nauseous. And I know I need to eat breakfast because I'm not sure if they're doing lunch right now. But I'm so sick to my stomach that I can't eat. And I don't have a pantry. I don't necessarily have the ability to have a healthy meal based on when my body is hungry and feeling up to eating. I have to manage that around other people's schedules of when do they do feedings, when do they do food give outs. So trauma and managing life becomes increasingly difficult when you're sick. SAMHSA has done quite a few studies on trauma's impact on homelessness. They definitely recommend their information. So we'll go through some basics of resources. I don't tend to go through like a list of resources. I'm going to show, just in case anybody doesn't know about 211, I'm going to talk a little bit about 211 at the end. But there are a significant number of resources out in the community. The hardest part is supporting someone and engaging with them. I don't know where I'm sleeping, but I know I need to be at an 8 a.m. appointment. I have no idea how I'm going to get there. I don't necessarily trust that my phone's going to stay charged to wake me up on time. The nature of working within a system and trying to make appointments for DHS to get a hotel voucher, trying to make an appointment with Voc Rehab for employment services and support, trying to get to treatment appointments. We largely function as a walk-in clinic because just managing your day without a lot of the anchors that folks who are housed like myself need. I need my cup of coffee in the morning. I need to get up and follow a routine. A lot of our folks can't do that. Of course, gaps in the system. There's always gaps in our systems. Shelter barriers are pretty key too. I think, when you're thinking about cleanliness and when you're thinking about taking care of yourself and immunocompromised and what do I need to do to stay healthy while I'm going through treatment, living in a large congregate shelter that has 400 people around you, it's very complicated. Sleeping while someone's screaming next to you, it's difficult. So cancer risk. There is a surprising disparity in terms of, we do a ton of research on screening. We do not do that much research on treatment or treatment outcomes. Obviously, increased rates of risk factors. So substance use, mental health conditions, pre-existing medical conditions that all kind of contributed to homelessness and cancer are very prevalent for homeless folks. I think one of the really shocking things when I kind of started experiencing working with people that were both unhoused and were experiencing cancer treatment was, I still laugh at myself a little bit, but you're expected to work the whole way through treatment. Disability is not necessarily accessible, even if you are exhausted and nauseous and in pain and can't do this anymore. And you're on the street and I was completely blown away. What we do know in terms of treatment, we know that people typically are diagnosed at a later stage. They are typically diagnosed in terms of I believe you guys call it a distant tumor stage, when the tumors or the cancer has spread throughout the body to distant areas. We know that there is deferred treatments. Women with breast cancer, where breast cancer is one of the primary diagnoses of cancer for our female homeless population. And they have an increased mortality rate. They were, on average, mean time to treatment deferring for about 98 days. I gather from the oncology research that receiving treatment within 21 to 60 days is ideal, moving quickly on what you found out. That's associated with positive outcomes. But when you're not housed, sometimes treatment becomes less important in the day. The most common reasons cited for the delay or the deferral of treatment were having nowhere to recover after surgery, comorbidities, psychiatric illnesses, interfering with treatment. Of course, we have a lot of folks that are coping with this experience of homelessness by getting very, very, very intoxicated. And that's a good reason to miss appointments sometimes. And concerns about the cost of care. You know, not everywhere in the US expanded Medicaid. And so it is still very much a financial burden for a lot of folks out in the world. Especially, like I said, in that donut hole, if you are making too much money for Medicaid, but you are not actually doing that well in terms of that $25.33 an hour here in Colorado to afford that 2-bedroom apartment, treatment and copays and transportation costs build up real quick. The Detroit study at the bottom, the epidemiology of cancer, this was actually one of the larger studies. They looked at 388 patients. Nearly 1/3 of cancer cases were diagnosed with the distant tumor stage. These were their first primary cancer diagnoses. About 39 of those 388 were diagnosed with additional cancers. Homeless men experienced greater rates of lung and bronchus cancer compared with men in the referent cancer population, so folks that were housed and not identified as people experiencing homelessness. As I stated, breast cancer was the most commonly diagnosed cancer amongst homeless women, but surprisingly, it was not a higher rate for that. The higher rate actually was cancers of the female genital system. That accounted for about a little over 1/4 of first primary invasive cancers, with an excess of an 83% incident rate. So about 83% increase among homeless women versus housed women experiencing that. They noted an excess of 193% in the incidence of cervical cancer and an excess of 138% in terms of ovarian cancer incidence. I kind of wondered if there was some intersection there amongst a large proportion of women experiencing homelessness at some point are required or forced into doing some kind of sex work. And so I wondered if there was some interaction between STD rates, increased STD rates in sex work, and also, you know, STD rates leading to increases in cervical and ovarian cancers. But yeah, it's surprising how little, it's surprising how little effort we have put into in terms of studying research around outcomes and treatment. It is not that surprising in my experience of working with the homeless. I understand research. You really kind of want to work with as many people as you can from start to end of the study. And my folks are very transient. We don't do a whole lot of start to ends. We do a lot of starts, and sometimes we get to do the end later on when they come back around. But the transient nature of our population just makes research hard. Housing. We are a housing first agency. Housing first is a mentality. It's also a treatment model or support model that essentially says it is not reasonable to expect someone to get sober while living in a tent on the street. So housing first, lead with housing, and then work on the life issues, and then work on the factors that lead to incarceration, that lead to, you know, becoming a nuisance in the neighborhood, is how I'll say it. So we do housing, and we do housing anywhere we can. These are two of our most recent properties. Renaissance Downtown Lofts is a recent full build for us. And then Fusion Studios is a conversion of a hotel that we purchased out on Quebec. They put little kitchenettes in every single one. We largely see and house single adults. We tend to work with the sickest of the sick. We tend to be like the bottom safety net agency. And so a lot of the folks that we work with are the folks that are not houseable almost anywhere else. Fusion Studios is a mixture of folks that have been either evicted from or are sex offenders, people with arson charges, folks who literally can't be housed anywhere else, and what we call 2765 clients, so people that are court ordered due to the nature of their mental health disorders. They don't necessarily maintain engagement in psychiatric services, so they're more or less court ordered to take medications and to remain engaged in services in some way due to whichever charge they got in the first place. Healthcare, this is my world. 15,000 patients served last year. We tried to see a lot of people. Right now we are doing telemedicine. We have these fun things we call nursing backpacks. We are telemedicine setups with a wireless card and a big battery and everything together to go out on the street and just see the person right there where they're at. We do a ton of telephone-based stuff right now. We do a ton of street outreach. This is the nurse backpack. It is huge and it's very heavy, but it comes with an otoscope. It comes with an electronic set of pretty much everything to take vitals and to do a physical exam through a laptop. So the provider stays here, the nurse goes out, maybe with a medical assistant or a social worker or case manager, and does the visit. So Stout Street Health Center, that is my home. We have a satellite clinic out at West Colfax and Sheridan, the West End Health Center. We have a satellite clinic at St. Francis Day Shelter. We do primary care, psych prescribing, behavioral health services. Instead of calling it mental health, I call it behavioral health because I also work with people on high blood pressure, on diabetes management, on new experiences of cancer, new diagnoses. And then we have this really cool role that I had not heard of before called a patient navigator. And literally their job is to find specialty services, to help people get connected, to manage referrals. My partner recently had shoulder surgery and bless him, he barely navigated that himself. And so for many of my folks, having someone who's experienced in the health system, who knows how to get appointments scheduled, who can take them to their appointment if we need them to, who can cab them or give them bus tickets to get there if they're motivated. It's pretty key. So tips and tricks, providing services to a homeless population. Maslow's hierarchy of needs. Very, very simply, we are all trying to get our needs met in this world, and the basic needs come first. If I do not know where I'm going to eat and I am starving, that is my primary focus. If my focus is on housing at that moment and I don't know where I'm going to stay, yes, you might be telling me that it is absolutely important that I go and get this tumor staged and figure out where I'm at. We need this information as soon as possible to get you into treatment. But I have that DHS appointment tomorrow and I know that I'm not going to make it. I'm not going to get that voucher that I need to get if I don't show up first thing in the morning. And I know that you scheduled that appointment at 8:30 or 9, but sorry, I missed it because I had to go to DHS. Shelter versus street homelessness is, I think, a little confusing or surprising to people. Shelter reality is that it's easier for you to stay clean. You have bathroom access. It's a little different right now with COVID. They've been putting out hand washing stations and porta potties. So if you have a port, you can clean your port. You have access to some facilities though in shelters, but it's also easier to pick up parasites, and coughs and colds are constant. Takes organization and self-management skills as well to use the shelters. Some of my sickest folks are the folks that get kicked out of shelters because they're either too high or they're too aggressive or they're too disordered and they're freaking other people out. It's harder to have privacy in these spaces, and theft is frequent. if I have high value meds or really any meds, and I need to go take a shower and I put my backpack right outside of that shower stall, you can almost bet money that my meds are now gone. We pretty much just are constantly replacing meds for people. So it's not necessarily the thing that means someone's not going to get what they need to. We will do daily fills, we'll do weekly fills, whatever is best for the person. But theft is frequent. If you've got pain meds, you can be assaulted for your pain meds, you know. Street realities, I always oftentimes say that if I was homeless, I don't know that I could stay in a shelter. Street reality, cleanliness is harder. You need to know where things are. You need to know how to navigate the city on the bus system. You need to know how to walk and find the right places to get meals. But it's easier to stay healthy if you're staying in a tent on the street, especially if you're someone who's an isolated camper. We're seeing now through COVID, we were expecting really high rates of COVID in all of our populations, but the people that are staying in the tents have the lowest rate. The people that are staying in the shelters have a much higher rate because of shared surfaces, shared space, you know. So the more isolated you are, it means you're healthy, it means less theft, it oftentimes means less danger for you as well in terms of people coming in and bothering you while you're asleep. But it also means that it's more difficult to access services. That's why we try to have satellite locations further out. That concentration of services downtown is hard to work around for people. This is actually a wonderful, this cancertherapyadvisor.com website was fantastic. And I really feel like the author of this blog that went up navigating the homeless patient through cancer care, she had it right on the nose. She was kind of talking about how you hear this person's story, and as a human and as a caring human, you want to lean in and understand more and be there and try to navigate all of these problems with this person. But the reality is that sometimes that person doesn't want to discuss those with you. Sometimes that person is already guarded through mental health stuff going on for them. And sometimes it's intrusive. Sometimes it's the 17th time that day they've had to think about the reality that they can't get somewhere or figure out what they need. And so she shared this list of questions that were just right there, you know, using the skills that they have, using the resources that they have, not trying to reinvent the wheel for them. They know how the wheel works. Most of our folks are not new to cancer, not new to homelessness, even if they are new to cancer treatment, and they have a wider knowledge of resources and skills for getting around this world while struggling than I think I will ever know. But really kind of digging in around where do we truly need to start to address the problem, figuring out access to food, figuring out supports. Is there really nowhere else to stay? Is there some family therapy that could happen to allow them to stay? You know, how can we work around these things? Motivational interviewing is huge for my folks, whether you're a clinician or not. It is, we have our medical assistants use it. We have our safety staff. We don't like security staff. Safety staff use it. It is simply the way of asking open-ended questions in a way that helps someone talk to you about what's important to them and going through it with them to figure out what are their goals and where do their goals interact and intersect with your treatment team goals. Figuring out, okay, so if this going to DHS is that important, then I absolutely am not going to schedule that appointment at the same time. I'm going to try to schedule their appointment later in the afternoon. I'm going to try to find resources for them in terms of transportation. I could not recall what the agency was. I had a gentleman going through colorectal cancer treatment, and he has very poorly controlled diabetes, as much as I have tried to teach him better diet and nutrition. He likes soda quite a bit, and he frequently would have some low or high blood sugar events trying to get to his chemo appointments because the chemotherapy place was up a hill. He would get to the bottom of the hill, stare up it, and then be like, I can't get up this hill. He'd have to sit down on the bench and rest. And there was an agency that the treatment center connected him with that just picked him up at whatever street corner he was staying at that day. He called them and said, hey, this is the address today. Okay, they picked him up and brought him right up that hill, worked around it. So assisting with resources where you can. The other piece to know about our folks is that most of them do not want as much time and information in one sitting as many other patients do. Most of our therapy appointments are about 30 minutes, whereas an average, private practice therapy appointment might be an hour. And a lot of my clients can't really sit past about 15 minutes. They gotta go. They got a thing, they got something going on, or they've just gotten a little bit too claustrophobic being inside for my chronically homeless folks, or, the hallucinations or whatever's kind of going on for them in terms of their internal experiences is intensifying the longer they're sitting with me. So a lot of our folks leave quickly during therapy. So small bites of info, kind of organizing the task on your side as much as you can. Don't try to give out paper, bless them. They will lose it almost immediately, or they just won't look at it. But giving them one resource at a time. I really like 211 Colorado. It is a national system run by United Way. We have it in Florida. You can call it, same as 411 on the telephone system. People can just get on there and call 211. For people that are tech savvy or have access to a smartphone or have access to when in non-COVID times when the library is open and allowing people to use computers, using resources that way. And oftentimes I just search for resource myself. A lot of our agencies and a lot of our systems are privately run, small nonprofits. And so things get brought up and they work for a year or two and then they close down and disappear. So staying on top of resources and resource booklets has just been an effort and frustration in my experience. So just looking at that time and kind of seeing what do I need to have for this person.
Leah, I'm sorry to interrupt. We're running a little short on time. Are you getting to the point where we might entertain some questions?
I am absolutely there. So this is COVID-19, and anybody who wants to look at the slides for this later, the main thing to know is that we have protective action hotel rooms, and there is a phone number in the slides to call and have patients call to get screened for a hotel room. If you have someone who's homeless and has cancer, which increases their risk for COVID, for complications from COVID, there's a phone number in there to call. But yeah, any questions?
One of the things that I know came to mind, and certainly I open it to the rest who've attended, is we who have worked in the cancer care realm have faced the challenge with regard to when one of our patients is experiencing homelessness. Who at the coalition can we reach out to help coordinate services that might be available to them and help them become eligible for whatever is currently out there?
Yeah. Honestly, I think I would actually say probably connect with me first, and then I can kind of direct you, because we have, with 600 employees, we have a lot of different programs. We have a family support program. We have the PATH program. It's a sort of like an intensive case management style program for people that experience severe mental illness. So depending on your client and depending on what's going on for them, that diverts them to different things, different programs within us. They're also just to walk in. We're not to be honest, we're not a great phone agency. One of the biggest struggles that we have is that our front desk doesn't have time to answer the phone because we're walk-in based. Most of our people don't use phones that often. So just sending the client on over to talk to us or coming over to meet with us. We have case management available every day, walk-in style. Most of our appointments are available every day, walk-in style. I would say psych prescribing is the hardest one.
If we were to reach out to you, is it best to call you directly or send you an email, and in terms of how that would look?
Email. Let me just click through to the very end. I put my email in there. We're doing so much with COVID. Email.
Okay, very good. Thank you. That's awesome. And then a quick question. One of the things we've experienced too, and you've alluded to this, is the likelihood that medications are stolen. Do you have an option for anyone to have lockers or any other safe way they can store them?
No, unfortunately. What we've seen, I don't know if anybody remembers the news stories that came up for a little while. Denver Rescue Mission and Samaritan House downtown put up some belongings lockers with some kind of requirements around people engaging in services to access them. And they took them down about 6 months later due to the amount of aggressive incidences that were happening from them. So unfortunately, we do not. We tend to have people go on to weekly or daily fills when they're continuing to get meds stolen, because it's just simply easier for them to just walk in and pick up a new fill. There's no copays or charges for it. If we filled it through Medicaid once and Medicaid won't refill it again, we'll just eat the cost. We don't charge clients anything. And so, yeah, it doesn't mind. It's not a problem for us to replace meds.
Okay, very good. Thank you. Does anyone else have a question?
Aaliyah, this is Carlin. You are such an amazing inspiration to all of us. And we definitely want to make sure that the people who are not here today hear your presentation and receive your resources. So efforts are already underway to make that possible. If you had a concluding message or thought to share with people or people who ask how they can help you, what would you say to our 185 task force members?
I think one of the biggest struggles for most people who are not me, who aren't trying to necessarily work only with homeless folks or do this kind of particular work as their focus of their career, is figuring out how to adapt enough to work with our clients. I think you meet those clients and you really want to support them through treatment, but their impairment is so severe. Their life is so complicated right now that it just doesn't work. And so the thing that I would tell them, the thing that I would want everyone to just kind of know is just making today better is the point. In my field, we oftentimes say you can't judge your success based on outcomes. You can't look at how your clients are doing and then kind of feel like, yeah, I'm doing a good job, because there's too much that affects that. And so if you spent, an hour with one of my folks and you made eye contact and you didn't treat them like they were stupid for not making that appointment, and you listened to their priority, for 10 minutes, even if you knew at the end of the day you weren't going to be able to help with whatever that resource was, or you couldn't solve all the problems in their world, the fact that you listened and that you did that 1 hour of time with them made a bigger difference in their long term than you know. I think health guardedness, healthcare, a lot of our folks have a lot of healthcare trauma. They've had providers disrespect them. They've had people treat them like they're dumber than they are. They've had people paternalistically take over their choices because of our own drive for trying to help or protect this person. And so anytime that we're treating a client or a patient with respect and listening to them is meaningful. It's important. Even if we didn't solve their problems and we didn't connect them in the way that they or I might have wanted in that moment.
I think I paraphrased you.
Yes. Thank you. Thank you very much. Well, if there are other questions that come up a little bit later, we have Aaliyah's contact information. We so appreciate the information you shared with us today. Sorry that we didn't have enough time to cover all of the slides, but I'm glad you're making them available that we can post them on our website. So thank you very much. You are welcome to stay on the meeting with us as we go over a couple other things, or if you need to jump off, that's okay too.
I got a lot to do. Have a good day, everybody.
All right.
Thank you so much.